The most recent updates for the non-covalent BTK inhibitors were presented at the ESH 2021 meeting, where I had presented an updated data set on Pirtobrutinib, or formerly LOXO 305. This molecule was tested in patients with CLL and other B-cell lymphomas. Results were quite impressive in terms of a response rate of 68% in patients who had all previously received a covalent BTK inhibitor, including 40% who also received venetoclax. Responses appeared durable. The median progression-free survival for the entire cohort, with a median number of prior therapies of 3, was not reached. In the double exposed patient population, those who had received a BTK inhibitor and venetoclax, with a median number of prior therapies of 5, the median progression-free survival was reached at 18 months. The safety profile of Pirtobrutinib looked impressive: 1% discontinuation rate due to adverse events, overall 2% AFib or aflutter, and very few high-grade toxicities associated with the molecule. So overall, it was well tolerated. It was active, particularly in a patient population who had seen a prior covalent BTK inhibitor, regardless of the reason for its discontinuation, even in the setting of CYS481 mutant disease. The other BTK inhibitor, non-covalent inhibitor that was presented at the ASH meeting by Jennifer Woyak, was Nemtabrutinib, formerly RQL 531. This molecule has also been tested in patients with CLL and other B-cell malignancies. The go-forward dose was 65 milligrams, which was given to, I believe, 51 or 55 patients. I'm forgetting the number. Overall, it was well tolerated. Overall, it was active with a response rate of approximately 58%. They didn't present PFS, but they did present duration of response, which median duration of response was not reached for the responders that were noted. And then in terms of the adverse event profile, there were more adverse events associated with this molecule. A discontinuation rate due to adverse event was approximately 8%. And there were about 8 or 10 different AEs that reached a greater than or equal to 20% rate associated with the molecule. So overall, that molecule is continuing to be studied in clinical trials. Neither molecule are yet approved for CLL, and so we're only having access to them in the context of clinical research. The LOXO molecule, I know a little bit more, is being studied in the frontline setting versus chemotherapy or chemoimmunotherapy versus ibrutinib. In the relapse refractory setting as a monotherapy, it's being compared to idelalisib or BR as investigator's choice. And then there's a time-limited protocol, which includes Ven-R plus or minus LOXO 305. So lots of different ways for patients to get access to this molecule in the context of research. No availability in the context of clinical practice at that time, but it's certainly meeting an important unmet need for patients.